Hello, myself Dr. Santosh Kumar, MBBS, MD from PMCH Patna and postgraduate diploma in advanced diabetes from Royal College of Physicians. Today I am going to discuss about the latest update in hypertension. As per WHO, nearly 63% of total death in India are due to non-communicable disease, of which 27% are attributed to CVD, which affects 45% people in 40 to 69 age group. Raised blood pressure is among the most important risk factor for CVD. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care and poor follow-up. First, in India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension and did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines, and the inclusion of optimal and essential treatment paradigm attempts to address the issues that in resources poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimum standards of care to allow a specification of essential standard of care for low resources settings. Second, the AHA or ACC has released a scientific statement in 2021 offering new guidelines for management of stage 1 hypertension among patients with low ASCVD risk. Among low-risk adults with stage 1 hypertension, management starts with non-pharmacologic therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacologic therapy. Number 3, acute respiratory distress syndrome is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory functions in people with COVID-19 induced ARDS. Number 4, lowering systolic blood pressure target down to the 110 to less than 130 mmHg range substantially reduced cardiovascular adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. Finding from now a second major trial supporting a low target could unite the guidelines, which even among US professional societies range from threshold of 130 to 150 mmHg. Fifth, with regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP measurement, but also on out-of-office measurement, such as ambulatory BP monitoring or home blood pressure monitoring. 24-hour and nighttime blood pressure measurements were associated with greater risk of mortality and a composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 mmHg increase in systolic and 10 mmHg increase in diastolic blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Number 6, most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower blood pressure target, to start antihypertensive therapy with an initial dual fixed dose combination of ACE1 or ARB plus calcium channel blocker or diuretics. Number 7, since early July 2018, products containing valsartans have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. That is, NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Jiangling, Huai, manufacturing site where the highest level of contaminants were found, every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs would lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by significant increase in the rate of emergency department visit of +6%. Next, number 8, the HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in the endpoints, including death. The HYGEA chemotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exert a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP different during sleep. The respiratory reduction rate for the cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatments. It's all over.